Welcome to Science News from the Resuscitation Science Symposium and the American Heart Association Scientific Sessions. I'm Nichol from the University of Washington Harborview Center for Pre-Hospital Emergency Care. I am here with Dr. Niklas Nielsen from Lund University, who has just presented the results of his TTM trial of hypothermia in patients hospitalized after resuscitation from cardiac arrest. Niklas, thank you for meeting with us. Tell us about the study. Tell us what you did and what you found.
Yeah, the trial is, as you indicated, out-of-hospital cardiac arrest patients with a presumed cardiac cause of arrest, adult patients, and we randomized them to two strict target temperature regimes, one aiming at 33 degrees, which is standard guideline practice, and the other arm was treated at 36 degrees. And we chose 36 because it was the temperature that the patients were admitted with in a large registry that we have. And it was also a temperature that did not allow fever to develop during the intervention phase.
That's very interesting because people have studied this question previously, and there was an ongoing debate before your trial whether the benefit was cooling or whether the benefit was fever reduction. What did you find in your trial?
The main outcome in the trial was survival until the end of the trial, and we also had a main secondary outcome that was neurological function at 6 months after the arrest. And the findings were that neither on survival or neurological outcome we could demonstrate a benefit of 33 degrees. The groups were very similar in their outcomes, both around 50% survival and a little more poor neurological outcome and death in a composite outcome.
So sometimes when a study fails to show a benefit, people wonder whether that's because the study physicians were not able to deliver the intervention. Were you able to cool the people, and were you able to maintain relative normothermia in both groups?
Yes, we actually feel that we were very successful in both groups, and we had a halfway interim analysis of this very specific issue just to reassure that we had a separation between the groups, and we could see that the 33 arm looked exactly the same as the patients that we cooled in a regular day-to-day practice did the last decade. And we came down to 33 degrees in almost all of the patients, very few exceptions to this, and it's clearly reported in the article as well. And the 36 group was very easy to maintain at 36 degrees actually. We were concerned about that in the start, if it would be a lot of variation around 36, but it was easy to manage the patients at 36. And as you can see from the publication, we really got the temperature correct in both groups.
You said publication. It has been published simultaneously in the New England Journal of Medicine.
Yeah, that's correct.
So our audience can find the paper and read your results. Sometimes how quickly we apply a therapy is important. It appears as though how quickly we apply hypothermia is particularly important in patients with myocardial infarction, but you studied cardiac arrest.
Yeah.
Were you able to cool the patients who were supposed to be cooled quickly, and did that contribute to the outcome?
You can always argue about when the importance of early versus late start of cooling and also achieving the target temperature. There are, to my knowledge, very scarce data that would support that early cooling or early reaching of the target temperature is beneficial. And we, in the trial, there was, of course, a few extra minutes that went on for randomization to the two arms, but otherwise they were treated as in regular day-to-day clinical practice.
And so there were two prior trials that showed benefit. One used a cooling duration of 12 hours. One used a cooling duration of 24 hours. How long did you cool your patients, and was that associated with outcome?
We had an intervention period of 36 hours, and we had a 4-hour phase of achieving the target temperature, but we also instructed to do it as quickly as possible in the 33 group, while the 36 groups, they obviously were kept on 36. And then we had 24 hours of maintenance and 8 hours of rewarming.
Sometimes studies which fail to show benefit do so because they were not large enough to detect a clinically important difference. How large was your study, and do you think you had enough power to detect important differences?
Yeah, we in our power calculations, we initially aimed for 850 patients, but then we decided to increase a little bit more to have a margin. So we aimed for 950, and we randomized 950 patients during the 2.5 years of the study conduct.
So how will the results of your study and the other trial impact on the guidelines in clinical practice?
I think they will have a large impact on clinical practice and on guidelines. Both are in their respective field the largest trials investigating this issue, and both are very robust in their no difference between the groups. So I think that must be taken into account when discussing how to develop guidelines in the future. And I also think that they introduce a healthy skepticism that you should continuously challenge your guidelines and try to refine how we treat these patients. But I also think it's very important to acknowledge the earlier trials from 2002, that they have focused on this patient group that was a bit neglected before. So I think the overall survival has benefited a lot from the temperature management and hypothermia concept.
So one trial cooled for 12 hours, another trial cooled for 24 hours. You have shown that temperature cooling or temperature control for 36 hours is not associated with any benefit.
And actually, we did not allow fever, which is very important to acknowledge, that this should not set us back to what we did before 2002 when we allowed fever. It's controlled temperature in both groups.
Do you think we now need a trial of 12 or 24 hours versus 36 hours?
I think that before we do that, we need to really assess our trial and maybe look even more into depth of temperature management before we can embark on a duration trial.
So we have ongoing questions about speed and depth of cooling. The trials that have been completed to date have used different durations of cooling and have provided different results. I think a practicing clinician now who is caring for someone who's resuscitated from cardiac arrest needs to control fever or control hyperthermia for at least 36 hours. I think we need to better understand and better compare and contrast to prior trials to understand whether there are additional benefits to actively cooling for 12 or 24 or 36 hours.
Yeah.
But I think you have done a wonderful body of work. I congratulate you for what I know was a difficult study to start and a difficult study to do, and you and your colleagues should be really proud of what is an incredible contribution to the field. Thank you very much.
Thank you.